But let's now move on to our final speaker. She completed BS and MS Statistics degree from the Statistical Center, my batchmate actually, where she also held a teaching position. She finished PhD Statistics at the School of Statistics, University of Minnesota. She also taught at Bowling Green State University before joining the Department of Statistics at Harvard T.H. Chan School of Public Health as a research scientist. Her research focused on communicable diseases. She will talk about the risk-benefit outcomes for studies in tuberculosis, treatment, and prevention. Please welcome Dr. Grace Montepiedra. Grace, you are still muted.
Can everyone hear me?
Yes.
And can you see my screen?
Okay. You can show it now, Grace.
Okay, can you see my screen?
Yeah.
Okay, thanks, Arniel, and good morning to everyone, and good evening to those of you who are on the East Coast. Great to see old teachers, old colleagues. Edsel, I noticed that you are chess is still a big part of your life. So anyway, we're segueing now to the field of clinical trials, which is what I've been involved with for the past maybe 15 years of my career. I've been doing a lot of clinical trials work in the field of HIV, and as well as in the field of tuberculosis, which is a very common comorbidity of populations with the HIV disease. So I'll be presenting really I'm not going to show any formulas or anything. The first part of my presentation is really going to be sort of a motivation behind the approach, a very simple motivation behind the approach specific to tuberculosis, and then 3 projects that sort of are using this approach. Couple of applied ones, and then 1 more methodological. So tuberculosis, I think many folks are aware that it's the #1 cause of death globally among infectious diseases. Philippines actually ranked number 3 in prevalence rate as of last year, according to WHO, with approximately about 1 million with active TB. And the most common type of TB is the drug-susceptible type. So it's a type of TB that's not resistant to any of the drugs. It needs 6 months to treat drug-susceptible TB. We need 6 months of 4 types of drugs: isoniazid, rifampicin, pyrazinamide, ethambutol, also known as HRZE. And then there's a more and more commonly appearing now, there's sort of starting to be an epidemic of what's now called multi-drug resistant TB starting in the 1990s. And what it is it's basically resistance to the basic background drugs for drug-susceptible TB, which is isoniazid and rifampicin. And it takes longer to treat it, 9 to 12 months of at least 5 drugs. And worse than that, it contains an injectable daily injectable regimen, which can be very painful and has lots of toxicities. It's also called the Bangladesh regimen. And then the most dangerous type of TB is extremely drug-resistant TB, which is resistance to many of the second-line drugs for treating MDR TB. So you know, just sort of a motivation. And suppose that a person has been diagnosed with MDR-TB, then suppose that in a clinical trial, there are two treatment options that are being studied. The one is the standard Bangladesh regimen, which is, as I mentioned earlier, it's a long, almost a year worth of 5 drugs containing an injectable, versus an experimental regimen B, which is a shorter regimen, which is 6 months, and will not be using an injectable. So given these two options, which one should you give? So what are the main factors that normally we test to sort of help us decide which one of the regimens is the better regimen? Well, the main factors are, of course, efficacy. You want to make sure that the regimen has a clinical benefit, that it will treat the disease. And of course, safety. You want to make sure that, you know, you want to minimize the risk, the toxicities of the drugs to the patient. There are also other factors that might play a role. There's the issue of tolerability. You know, will the patient be able to take the regimen for a long period of time without much issues? There's quality of life. Is it going to hinder daily activities of living? So there are these several factors, but the main factors are the ones that are typically being tested in clinical trial. And the standard approach is to have 2 sets of hypotheses. Usually there's a primary objective, which is usually the efficacy objective, which is usually a superiority, you know, which one's better, or a non-inferiority objective. So in this particular case, for example, would regimen B be non-inferior to regimen A? And then there's also going to be a safety objective, which is to compare the superiority of one regimen over the other. And sometimes safety is relegated to a secondary objective. So in the conventional approach, what we do is what we call analysis of outcomes. What that means is that you first look at one outcome, in this case, efficacy, and then you compare the 2 regimens. And then next you compare safety, and then you compare the 2 regimens with respect to that outcome. So suppose that we have 2 regimens, A and B. I think everybody's pretty familiar with this type of approach. And suppose that we have 3 patients assigned to each regimen. And suppose that regimen A had 74% success rate, regimen B had 65% who were cured using regimen B. The relative risk is 1.31, 95% CI, which is greater than 1. And so it shows that regimen A has a better success rate, treatment success rate than regimen B. However, when you look at the safety, when you compare the 2 regimens, turns out regimen A has more toxicities with 50% serious adverse event rate compared to regimen B with 40%. So the comparisons are in either direction depending on which outcome you're looking at, whether it's efficacy or safety. So the question is, does the clinical benefit derived from choosing regimen A outweigh the higher risk of toxicities from using that same regimen? So that's the issue with doing separate analysis of outcomes. When it comes down to actually making a choice, it's really hard to look at the risks versus the benefits in a quantifiable way. So the one approach to sort of help, you know, with making those kinds of decisions, the risk-benefit decision, is to think of the, you know, instead of analyzing outcomes, the approach would be to analyze patients. You know, you look at a patient and look at the overall, the totality of experience of that patient. So in this particular case, we look at the totality of experience of a patient with respect to both efficacy and safety. So if it's efficacy is binary and then toxicity or safety is binary outcome, then you have basically 4 possible outcomes. And among the 300 participants who were subjected to regimen A, they would belong to one of the four different possible combinations of the four possible outcomes. So the table at the top shows you the different distributions of the four possible outcomes for regimen A, and then for regimen B likewise. Now we can show those two tables. We can combine them into this table that you're seeing in this slide. But the important thing here is that those four possible outcomes could actually be ranked according to what we call desirability of outcome, where you prioritize these four different potential outcomes in terms of the patient experience. So if for example, between efficacy and safety, efficacy of a higher priority and safety of is the second priority, then if you look at the possible combinations, the four possible combinations, it makes sense that the most desirable outcome is treatment success with no toxicity. And then the least desirable outcome would be treatment failure, drug doesn't work for clinical benefit, and a toxicity occurs in the patient. So it's a very simple, just sort of showing a very simple scenario, very simple table. And the comparison, the distribution of the four possible outcomes for regimen A is shown in the second column, and for regimen B likewise in the third column. And there are, of course, many different issues that we would encounter with clinical trials, loss to follow-up, competing risks, and all that stuff. But for the sake of simplicity, just to drive the issue here, we would just use a Wilcoxon rank sum test, or any test that you could use for ranked outcomes. And it turns out it becomes now, instead of, for example, a non-inferiority comparison of efficacy and the superiority comparison with respect to safety, this will turn out to be just one superiority comparison of this, what we call risk-benefit outcome, this four-category outcome. And it turns out, with the superiority comparison, it turns out the Wilcoxon p-value turns out to be significant. One way to estimate sort of the effect, sort of the treatment effect of regimen A versus regimen B is to estimate the probability that a randomly chosen patient taking regimen A will have a better outcome than a randomly chosen patient taking regimen B. So that's one way to sort of estimate sort of the overall treatment effect with respect to risk-benefit outcome. Let's say in this case, we get 55.4% with a 95% CI that's above 50%, which basically tells us that regimen A is actually the better outcome in this, the better regimen in this case with respect to this risk-benefit outcome. So it's a sort of a simple example of how this risk-benefit approach, using this risk-benefit outcome, comes into play. So this was sort of popularized in the clinical, in the clinical literature by Scott Evans, who also belonged to our group at the School of Public Health. Was called the desirability of outcome ranking. It's getting to be more and more sort of a popular type of outcome, or we call it door outcome, and it's used in can be used. He generalized basically what has already been proposed in the past, as I'll show you in the next slide. Myself and some colleagues of mine at the School of Public Health sort of discussed the applications of this ranked outcome in the field of tuberculosis, treatment of tuberculosis. And as I mentioned earlier, there are, this type of outcome has been proposed in the past as a rule-based ranking scheme, first by Christy Chuang Stein and her colleagues in stat medicine back in the 1990s. Dean Fallman from the NIH, also back in the 1990s. So the sort of the rule-based method, ranking method that I mentioned earlier, is kind of sort of the similar approach as the Chuang-Stein and Fallman approach, but there are different other approaches, ways to prioritize the outcomes. Another approach is by doing a survey. You know, you give them all these different categories of patient outcomes, and the sort of a Delphi panel, what's called a Delphi panel, would be sort of ranking them. So a Delphi method is one approach. And then another approach that is actually quite interesting, much easier for participants to do, especially when you have a larger number of categories. It's what is called discrete choice experiments, very popular in marketing research. For those of you who are in that field, probably might have heard of it. And yeah, we're also looking into that as well. And now I'm going to be showing you some three projects that I've worked on with some colleagues of mine. One is an application to a TB prevention study. It's called Brief TB, and it was a clinical trial conducted by some of my colleagues at our center. It's a TB prevention trial that's comparing a short regimen of isoniazid and this other drug called rifapentine as an experimental regimen, compare it to the standard of care of giving 9 months of isoniazid for prevention of TB. So what's very common in the study of new regimens in TB prevention and TB disease treatment is shortening of regimens. Particularly in TB prevention, since patients are normally relatively healthier, you know, they don't really like to take 9 months of INH. It's too long, and there's problems of adherence, and you don't want, I mean, safety is a very big concern because this is a relatively healthy population. So in this Brief TB study, there were 3,000 HIV-infected adults and adolescents with TB infection who were randomized to the shorter regimen of 1 HP versus the standard of care of nine months of isoniazid. This was published at the New England Journal of Medicine just last year, and it was shown that 1 HP has non-inferior efficacy to the longer regimen of 9H. So it is a non-inferiority trial comparing the efficacy with similar TB incidence rates found between the two arms. Now there's a secondary safety comparison between the two, but the main results really like focusing on the efficacy. However, being also concerned with safety in a TB prevention study, we have decided to apply the risk-benefit outcome to this particular data by first asking a Delphi panel, what we call a Delphi panel of several stakeholders. These are clinicians, TB researchers, knowledgeable in the area of TB prevention. And they identified basically potential categories of the risk-benefit outcome. So in this particular case, there were 9 categories that they were asked to rank. And, you know, for the efficacy, there's TB or no TB. And then for safety, severity of toxicity is actually very important. So you could have a patient could either have a grade 2, a grade 3, a grade 4 AE, or the patient could die, right? So a patient in the study could either have no TB and did not have grade 2 adverse event, which is the best outcome, the most desirable outcome. So the patient was rank 1, and then the worst is if the patient died, which is number 9. And it was just a simple comparison of these ranks of patients. Each patient is assigned a rank, did a flow taxon rank sum test, and turned out that the 1 HP is superior to the longer regimen with respect to the Wilcoxon rank, with respect to the risk-benefit outcome. So it sort of really, it supports the non-inferiority sort of conclusion that was reported in the main paper. Another application of risk-benefit outcome that we've done is to look at another TB prevention trial on pregnant women. This is the TB Uprise trial that's also performed in our group, and I was the statistician in that study. And the basic objective is to compare. This is another non-inferiority trial, but of safety. In pregnant population, safety is always an important consideration. Efficacy is normally already assumed to be true, extrapolated from the adult studies to pregnant women. So to compare the maternal safety of initiating 6 months of TB prevention during pregnancy versus deferring to postpartum after the woman delivers. The concern there is the safety during pregnancy. So in this particular case, there were 956 HIV-infected pregnant women who were randomized to one of the two arms. And the study results, which was again published last year as well, was that it was found that we were able to show that initiating INH at pregnancy for prevention of TB is non-inferior, or we so-called just as safe as deferring it to after the woman delivers. There are, the main comparison here is safety, maternal safety, but there are so many other considerations. There's, of course, the efficacy, which is TB incidence rate, which was found to be similar between two arms, the maternal TB, but we also wanted to look at infant TB. So the maternal child health aspect of it, that TB prevention could also be beneficial for the children. And so we found that infant TB rates are very similar between the two arms. However, there was more maternal hepatotoxicity in the deferred arm. It turned out not to be significant, but we found more adverse pregnancy outcomes in the immediate arm, which is found to be significant. These are secondary comparisons. Adverse pregnancy outcomes are things like stillbirth, premature delivery, congenital anomalies, low birth weight. So given all these considerations in the mother and the infant, it begs the question, from the whole risk-benefit point of view, overall, when looking at all these different outcomes, primary and key secondary, was initiating 6 months of isoniazid just as worse than deferring it to delivery, so post-delivery. So I'm not going to give the full details, but basically what we did here was we had a more involved process of developing the composite outcome. What we basically did was we developed a maternal-infant composite outcome, which examined the safety and efficacy in both the mothers and the infants simultaneously. We used a focus group of 6 experts in TB research, and then we followed it with a 2-stage Delphi survey of 26 stakeholders, and we came up with this sort of a composite outcome, wherein the Delphi survey panel prioritized an outcome that consisted of mother-infant pair categories, showing whether if the mom had TB, the infant had TB, that's one category, etc. And then we compared the immediate versus the deferred INH, the TB preventive therapy, in the data set with respect to the composite outcome. The bottom line is we did find that between two arms, there was no significant difference, but we did find an interaction effect between the study arm and the ARV regimen with respect to this risk-benefit outcome. The manuscript is currently in review, and this was presented last year at the Union World Conference on Lung Health. And then finally, more of a, now segueing to a more methodological approach. We've also looked at using the risk-benefit outcome in designing and analyzing non-inferiority trials. Basically, non-inferiority trials are really probably the most commonly used type of design in the evaluation of TB regimens. And one of the major issues, and it's a very big area of debate, there's actually a couple of papers in clinical journals at PLSO Medicine that really discuss this issue, which is the determination of the non-inferiority margin. For example, in drug-susceptible TB, wherein the main hypothesis is the non-inferiority with respect to efficacy of new TB regimens for treatment of drug-susceptible TB, they basically were using like 6% as a non-inferiority margin. And the rationale behind that has been under debate. But our contention is that the non-inferiority margin should really be providing, quantifying the trade-off between the benefit and the risk. You know, the trade-off of allowing a non-inferiority margin on the efficacy should be due to perceived benefits of the regimen, whether it's because of safety, whether it's because of tolerability, whether it's because of quality of life. The non-inferiority margin should reflect in a quantifiable way the perceived benefit of an experimental regimen that allows it to have sort of lower efficacy, you know, which is what we usually do in non-inferiority trials, is we allow a non-inferiority margin, which is sort of a small loss in efficacy. And so this is my last slide. Some colleagues of mine at the center were able to have a unified sort of, we showed some equivalence between comparing the risk-benefit outcome with a non-inferiority trial, and we were able to quantify the risk-benefit trade-off using the risk-benefit outcome in comparing the two different arms. And we call it, we now introduce the concept of what we call a maximum allowable decrease in efficacy, or what we call MAID. And we propose to use that quantity to inform the non-inferiority margin in the non-inferiority trial. So this is sort of, we're planning to use it for many of our new non-inferiority trials we're going to be doing our group. It has been reviewed at the Statistics in Medicine, and hopefully it will be published very soon, and love to share with everyone once it's out there. And I think I'll end at this point.
Thank you very much, Grace.